that's what you want to do. That's perfect.
All right. So hopefully everyone can do this when you feel like you want to. Okay. So thank you, everyone. We have 3 cases today. So we're trying to fit the full 3 cases in, and I'll get started with first case. In this, I'll thank Dr. Ashley Jefferson for putting together the clinical history. This was an outside biopsy for a patient who is, I think, very likely to be seen in the near future at the VA. Or sorry, at UWMC. It's a 35-year-old male with acute kidney injury. The serum creatinine is 8 at the time of biopsy. Past medical history is type 2 diabetes with retinopathy, coronary artery disease, stenting in 2022, hypertension, gout, obesity, hyperlipidemia. The background creatinine was around 1.2, but then in October, he was admitted with shortness of breath, volume overload, and acute kidney injury, and his creatinine increased from 2.6 to 8 over 4 days, and he was started on hemodialysis. So he had a bunch of workup at that time, and they also noted that he had a liver mass, a 5.8 centimeter liver mass, and that was biopsied and shown to be a well-differentiated neuroendocrine tumor. Here's the biopsy of that. You can see this is like 2 millimeters of tissue and greatest dimension here. Look a little bit higher, it's a fairly uniform population of cells, and even higher, we see that the tumor consists of these well-differentiated cells that had immunohistochemical profile consistent with a well-differentiated neuroendocrine tumor. Further investigation showed that he had an active urine sediment and significant proteinuria and low hemoglobin. In addition, his complement level was C3 was low, but C4 was normal. There were no other really significant abnormalities in the serological studies. And so at this point, a diagnostic procedure was performed. And if people want to scribble in their what they're thinking differential diagnosis for this patient, this would be an opportunity before I go forward and show you the biopsy itself. Diabetic, active urine sediment, rapid progression in or rapid loss of renal function. Just progression of diabetes. Okay. Maybe no one's able to annotate, is that right? Someone could just scribble an X or something just to show that you can do it. That would be great. And if no one wants to annotate, I'll just move on. Okay, looks like it's working. We're just not there. So this is the biopsy from the patient. And we'll look at a little bit higher magnification. And we can see here there's some globally sclerotic glomeruli and other glomeruli that are patent. If people want to X out some of the globally sclerotic glomeruli and some of the patent glomeruli, or put a circle around patent glomeruli, that'd be great. Yeah, so there you see these black little circles are sclerotic. And then, yeah, that's not sclerotic, the yellow X, but that's patent, but it is abnormal. So it's difficult to determine. So why don't we move up to higher power here? And we can see some more obvious chronic injury. You can see the globally sclerotic glomeruli, and then a couple patent glomeruli, but the patent glomeruli all look abnormal. There's also tubular atrophy and interstitial fibrosis, and then we'll go a little bit higher. So here's a couple of the patent glomeruli, and are they normal? And then there's also, if you can see, there's also a globally sclerotic glomeruli, or 2 actually, if people can, a portion of an additional glomeruli. If people can see those in here, I would ask you to try to X those out. If you need some help, this one here, that's one that's disappearing into the parenchyma, and then over here is another that's just sort of at the edge.
Kelly, I'll just bring to your attention, sorry, one comment in the chat is there, Ian mentions, were there any recent infections in this patient?
We'll get to that.
Oh, sorry, sure.
Yeah. So, and I think that that question is promoted by looking at these abnormal glomeruli here. And one thing that's notable is that they're hypercellular. And I hope everyone can appreciate that there's a unique cell here, a neutrophil that's present. And if people can sort of hone in on the neutrophils and put some dots or marks where they see neutrophils, that would be great, just to let me know that you're paying attention. I'm not quite seeing anything yet, but I'll give you a little bit of help. So all these multi-enucleated are the polymorphonuclear cells. So the multilobulated nuclei are neutrophils, and they're all over the place. And so when we see hypercellular glomeruli with prominent neutrophil infiltration, that's an exudative glomerulonephritis. And here and we see that as well. There's also some, silver staining matrix that's present here as well. So there's a increased amount of matrix that's present, which we usually associate that with chronic injury. So we have to sort of figure out what that is potentially due to in this patient as well. Another glomerulus here. Wow, it still has an X on it. That's great. That has really prominent exudative features, and also this areas with increased mesangium. Again, some periglomerular fibrosis, chronic injury, and another at higher power, showing some of the same changes. So here's a glomerulus that's relatively uninvolved, and I guess I can probably get rid of these annotations somehow.
Sorry, I got you there.
Oh, you got me. Thanks. Good. So here, this one doesn't show the hypercellularity, but we do see sort of diffuse mesangial sclerosis that's focally nodular. And then here's another glomerulus with diffuse mesangial sclerosis with this focal nodule. So it looks like a couple of the glomeruli are not involved with the exudative process, and they show this background of diabetic nephropathy. And so we have histologic evidence of a background of diabetic nephropathy with a superimposed exudative glomerulonephritis. To further work that up, we did immunofluorescence. And here we see a bunch of IgG and then a bunch of C3. And so this is very characteristic of an infectious associated glomerulonephritis. And then when we look at the electron microscopy, we see that there's presence of electron-dense deposits here in the subepithelial region, but also electron-dense deposits that are present within the mesangial region. Here's some more. We see even some that are sort of infiltrating the basement membranes, as well as those that are present in the mesangial regions. And then here we see one of these subepithelial deposits that's relatively large. It's not quite hump-like, but it's one of those deposits that we associate with a infectious associated glomerulonephritis. So we have a C3 dominant glomerulonephritis with exudative features and a background of diabetic nephropathy with a fair amount of chronic injury. Now, in this instance, since we have a lot of IgG deposition, it really doesn't meet criteria for C3 glomerulonephritis. If we didn't have IgG, that would be in the consideration. If you have a C3 dominant glomerulonephritis with exudative features, our differential diagnosis is post-infectious, an infection-associated glomerulonephritis. That's the obvious favored diagnosis in this case that really prompts an infectious workup and also is helpful to follow the clinical course to support that diagnosis. If we didn't have the IgG, we'd be also thinking of C3 glomerulonephritis, which would prompt maybe additional laboratory workup, genetic studies, and also following of the clinical course. One thing to note is that post-infectious glomerulonephritis is really defined by sort of the prototypical cases that we see after a streptococcal infection. These are typically group A beta hemolytic streptococci. The risk can be actually quite high, but most of the cases appear to be subclinical. And one thing to note when you're looking for an infectious source in a case like this is that the biopsy is actually usually done oftentimes after the infection is cleared. So for a streptococcal infection, you might only have a clinical history of the infection. You might not be the person that is actually diagnosing the infection. It may have been diagnosed before, or you may only detect anti-strep antibodies or something that actually tells you that there was an infection at that time, because you may not be able, or you're oftentimes not able to actually identify an active infection. So clinical course, the liver mass was felt to be non-surgical. After further workup for blood cultures and echo, the patient was started on a 6-week course of oral prednisone plus MMF, and the patient remains dialysis dependent. So no clear source of an infection in this case, but what looks like a post-infectious glomerulonephritis. But he also had that liver tumor. And so we went and searched to see, what is the link between neuroendocrine tumors and C3 dominant exudative glomerulonephritis. And this was when I did the Google search, and it's really nice. I think everyone appreciates the AI assist with this, because it not only deciphers all the literature, and it gives you this nice paragraph that summarizes what all the literature tells you, and then it even provides links to it. And so this was really helpful in this case. And after doing that search, we found that stuff happens. So there's no obvious link between these two things, and I think that's a mystery to be solved at this point. Any questions? Or looks like we have a lot of chats. Yes, the GVM was thick in this case. That supports the background diabetic nephropathy. And if there are any other questions, you can either unmute or we can move on to the next case. Okay. So case 2, and I'll pass it on to Karen.
Thanks, Kelly. So this is a case I'll be presenting who we saw at Montlake within the last couple months. And I'll just acknowledge up front that quite a few different nephrologists were involved in his care because he had a fairly prolonged hospital course. I just happened to get the baton at a kind of interesting time. So this was a 60-year-old man who initially presented with 1 month of periumbilical pain, worsening nausea, and a rash on his hands, which had been present for about a week, but had spread upwards through his arms. It had some blistering, but was non-painful and non-pruritic. His medical and social history, possibly hypertension. He hadn't really engaged with medical care very consistently. He had substance use disorder and had been on methadone for quite a long time, and active cocaine use about once per month. And then a 47-pack year smoking history, quit 1 month prior, and a history of fairly unstable housing, although he was currently in a transitional supportive housing. Slide. So his initial exam was notable for generally ill appearance, and you can see the rash there, which was predominantly on his hands, and it did go up through his arms a little bit as well. He did not have edema. He had some tenderness in his abdomen. And you can see his initial labs were pretty impressive. His creatinine was 22. We didn't have any recent baseline on him. The BN of 184, hyperkalemia. You can see his CBC, he was anemic, somewhat low platelets, and then his LFTs, including albumin, were all fairly normal. His urinalysis wasn't really readable because of the color, at least that's what the computer said, except there were quite a few red blood cells. He was actually essentially functionally anuric though, so there weren't really further urine studies that were able to be done at that time. I think he just basically had some small sample when he came in the door. His UTOX on that initial test though was positive for methadone and cocaine. And then he got an ultrasound of his kidneys, which other than some chronic medical renal disease, was fairly unremarkable. So at that point, further workup was undertaken, notable for some elevated inflammatory markers, including ESR 98. His haptoglobin was low, but the blood smear did not have any evidence of hemolysis. His serologic workup was essentially entirely negative, other than a low C3, which was 64, and a normal C4, SPEP, free light chains, all of that was negative. And he had an initial blood culture, which was also negative. He was ultimately started on dialysis fairly quickly and was anuric. And unfortunately, largely, I think, for patient reasons, there were a lot of delays in procedures and testing for him. But ultimately, he actually got a skin biopsy first of this rash, which showed a leukocytoclastic small vessel vasculitis. And then on day 8, was able to get a kidney biopsy.
Okay. Anyone want to share differentials at this point, or what they're thinking? Or maybe not. Go straight to the biopsy. Okay. So here's a low power view of the entire biopsy. Most of it is renal cortex. We see 2 pieces here, and it's probably very difficult at that level to make out what's going on, but I hope that at this slightly higher magnification, you can see that there are glomeruli present, and every single one of them looks abnormal. So if someone can see an abnormal glomerulus, why don't you put an X on it? Yeah, so pretty much every single glomerulus in there is abnormal. And we'll look at them at higher power. One thing also to notice is that some of these tubules have wide open lumina and attenuated brush border. There's also some pink or a little bit red material present in several tubules, suggesting that there's some tubular injury and red blood cell casts present. A little bit higher magnification, and I don't know how to clear these, so if I can get Daniel to clear annotations as we go, that'd be great. Thanks. A little higher magnification, you can see all these glomeruli, and every single one of them looks like they're involved by crescents. In fact, you can barely make out the structure of the glomerulus. It's just mostly cells that are compressing glomerular tufts, and not much else to look at. At higher magnification, we can see, again, we have these glomerular tufts that are mostly squeezed by these cellular crescents. There's a little bit of eosinophilic material present within these crescents, suggesting that there's some fibrin as well. We see the red blood cells in the tubules, consistent with an acute glomerulonephritis. And again, more of these. So most of these are largely cellular, but you can see the lower one here with the spiral of red has some silver staining matrix material admixed with the cells. So there's a little bit of fibrous or matrix there. So there, a little bit of fibrocellular crescent formation, but mostly very acute and cellular. And here's another glomerulus. We're not really seeing much going on in the glomerular capillary loops, but they're mostly largely distorted by these cellular crescents. So we're not seeing the exudative features that we saw in the prior biopsy. What about immunofluorescence? So the immunofluorescence, the main finding was fibrinogen. So every single glomerulus in the immunofluorescence was involved by cellular crescents, and many of them showed fibrinogen that was just decorating the areas of crescent formation. It was positive in essentially all of the glomeruli. IgG was negative to trace, IgA trace, IgM trace, C3 negative to 2+, C1q trace to 1+, kappa and lambda trace to 1+. So there's very, very modest immune complex deposition. Maybe a little bit more C3 than anything else, and fibrinogen was the major finding here. So at this time, with the 2 pieces of information in the clinical history, we had a diffuse segmentally necrotizing glomerulonephritis that I interpreted as most likely a post-immune complex type. There are cellular crescents involving all of the sample glomeruli. And there's also the typical findings of acute tubular injury. Given the patient's clinical history, the possibility of like levamisole, or something like that causing the glomerulonephritis was something I thought should be considered, and I think the clinical team as well. And then we still had EM to look at. And so now we're left sort of in our intermediate stage, and we'll get back to the clinical story.
Yeah, so at this point, we had the biopsy come on a Monday morning with this possible levamisole-associated GN or posse-immune GN. Because levamisole GN is typically associated with positive ANCAs, that was rechecked and it remained negative. We did start him on steroids, and pending a plan likely for either rituximab or cyclophosphamide, but there were a few findings that weren't really explained other than also having the low ANCA. And he didn't really actually have a lot of cocaine exposure for his history, although I think that's obviously for interpretation. But the lack of explanation for his low haptoglobin, and he had a persistently low C3 checked multiple times, and was concerned just with his general clinical appearance that he could have some kind of underlying infection. I will also say that he had a bit of persistent mild thrombocytopenia, which we also didn't really have an explanation for. So we requested a TTE before committing him to long-term immune suppression to rule out an endocarditis. And the TTE ultimately showed a possible vegetation on his mitral valve, which was read as degenerative changes versus a vegetation, and ultimately pursued a TEE to better define that. And I think the TEE also showed similar findings, but they thought it looked more compatible with the vegetation than with a possible clot or degeneration. Otherwise, his heart looked relatively normal. And at this point, an infectious disease was involved. Like I said earlier, he had had a blood culture initially, and when we were suspicious for infection in this kind of week while we were getting the cardiac workup, repeated blood cultures a few times, and they were all negative. So he was tested for other causes of infection or of culture negative endocarditis, and I think that workup is on the next slide.
Oh, wait, sorry.
That's okay.
I inserted the electron
around this time, the EM also came back.
Yeah. So the EM was like every other specimen in this patient. All the glomeruli were involved by crescents, and so you can see what a mess this is. Here's the glomerular basement membrane. Here's maybe some endothelial cells. This is possibly mesangial region. Here's some glomerular basement membrane. We have a break here, some sort of cell present along this break, another cell here. So it's really difficult to sort of figure out what's in and what's out in a crescent like this. We have some areas like this. There's some electron dense material and looks like some cellular debris, organelle type stuff hanging out here too. So maybe these are immune deposits. And then in a few areas, something a little bit more like this. So, some electron dense deposits present on the subepithelial side of the basement membrane, subendothelial. So given that C3, given this clinical history and all this stuff, these I think, could be compatible with, immune deposits, and now I think brings back into the fold that maybe this isn't just a posse-immune thing, maybe this is an immune complex mediated thing. And then we had further biopsy discussion. So as I mentioned, electron microscopy found this material, which could be immune deposits, and the major immunoreactive was C3. Differential diagnosis at this time is ANCA negative posse immune. For me, the pro is it's really a diffuse process. When we see 100% of the glomeruli involved, ANCA has got to be, or anti-GBM has got to be at the top of the list. The con in this instance is there was no history of levamisole use, so nothing to link the cocaine use in the glomerulonephritis. But that's also usually ANCA positive. And then the presence of C3 and electron dense deposits. So pro for infection, the C3 and electron dense deposits. The con is really it's unusual to have every single glomerulus involved by crescents in a case of infection-associated glomerulonephritis. So at this time, we rendered the final diagnosis of diffuse segmentally necrotizing and crescentic glomerulonephritis of indeterminate type with acute tubular injury, and the clinical workup continued.
Yeah, so concurrent to this, he got a pretty complete infectious workup for culture negative causes of endocarditis, which returned slowly over the course of a week or so. But syphilis was negative, his enterovirus PCR was negative, brucella negative, chlamydia, Sataki, and pneumonia were both negative. The Coxiella screen, actually, the initial antibody screen was positive. And this, of course, piqued our interest, although infectious disease, who was involved at this point, said that actually oftentimes has cross-reactivity with Bartonella. And he really had no exposures that would make him at risk for Coxiella. He had spent essentially his entire life in the Seattle area. And the confirmatory test for Coxiella was ultimately negative. But his Bartonella testing did ultimately come back with very high titers. And it was actually both IgM for Quintana, and he also had prior IgG positivity for Henselae. And at this point, we were pretty suspicious that this was a Bartonella Quintana infectious endocarditis with a immune related GN or infection related GN. And a bit further exposure history just with these findings. Again, he never had any agricultural exposure, which would put him at risk for Coxiella. He'd always lived here, but he actually had a severe body lice infestation about 9 months prior to this. And that is how Bartonella Quintana is transmitted. So it's actually quite consistent with the history. So because of that, he was initiated on doxycycline and ultimately rifampin for treatment of Bartonella-associated endocarditis, and further immune suppression was held at that point. He was discharged on dialysis, and he remains on dialysis currently, although I've heard that he might be making more urine at this point, but that's the most recent update I have for him.
Okay, so this is a great example of how important it is to have really good clinical information to help guide pathology, especially with a case where you have essentially every single glomerulus is involved by crescents, and sometimes our interpretation can be limited, and we have to be a little bit cautious. But now, after all of that, we really have a case of Bartonella endocarditis associated glomerulonephritis, and I think we're fairly confident of that. It'll be interesting to see if this patient does recover. The biopsy showed, extensive crescents, so I'm very curious to see what recovery, if any, could happen from that. Any questions here? We have a few things in the chat, mostly interesting case. Story is he got lice from borrowing pants. Okay, so that's a lesson to be learned.
Yeah, he did say that he borrowed some pants, or he found some pants that looked really nice and were unused, and then they ended up getting lice from them. So it was sort of a tragic story that ultimately led to this 9 months later. I'll also just say on the follow-up, his skin biopsy, there was some final eye abstaining on that was done much later. I think he'd been discharged by then, but it was negative because I see Guyan's HSP, which I think was a really reasonable differential. It was negative for IgA and was actually pretty much negative for all staining except some C3. So they thought it looked like a leukocytoclastic vasculitis in the skin, but was not really consistent with a systemic vasculitis.
Thank you. Very interesting case. Maybe we can move on to the next. I just want to put a quick plug and remind everyone for these cases going forward. Always want to be, because we do post these videos, so let's make sure we're always, if we're going to share any identifying information or pictures, to always make sure we consent the patients for these. And I'm not insinuating that we did not in this case, but just want to give another reminder in case others have used slides in the future. Yeah, we can move on to the next one.
There was one, Dr. Alpers made a comment
yes,
about how fast should we go for a wide molecular screen for pathogens in cases like this. And I think there is definitely a good reason to do that. I think especially in this instance where you have a culture negative case that could be endocarditis. There are tools to do that these days, and there are approaches to do that. It basically would require, I think, submitting a blood sample for essentially a very broad screening and sequencing analysis to look for a potential pathogen. But I don't think there's any rules or guidelines at this point of when we should do that. But I think it's definitely something that we can do at this point, and probably worth sort of discussing and thinking about. Okay, we can move on to case 3.
So this was also a recent case from UW, so a lot of different providers were involved. There's a 26-year-old with iron deficiency anemia and a VSD who had presented to the ED at the request of her PCP with pre-syncope and anemia, and we were ultimately consulted for AKI. So some of the clinical history and why she had actually gone to her PCP in the first place was that over the past few weeks, she had been having fatigue and pre-syncopal episodes. She had never actually lost consciousness. She had also had a rash on her legs that had resolved by the time we saw her, but she had a picture. It had coalescing red papules. It was not itchy or painful, and she actually thought it may be related to celiac disease as she was having diarrhea. And so she went on a gluten-free diet for 2 weeks, and the rash had resolved. She was also having some ankle and joint pain around the same time as the rash, and she was having diarrhea. Initially, she had thought it was from stopping her PO iron supplementation. She had no changes in urination, no hematuria, no dysuria. Her oral intake was interesting. She's vegan, and due to financial concerns, she was only eating half of a fast food meal every day. So she had quite poor intake. And because of this, she had actually been amenorrheic for the past 10 months. Her initial labs, or her vitals, her blood pressure was 90s to 100s, over 70s to 80s. She wasn't tachycardic. She was on room air. Her labs were notable for a creatinine of 1.6 with a BUN of 12. She also had a hemoglobin of 6, which is why her PCP had her come to the emergency department. The ferritin and the TSAT were obtained at her PCP office before she got blood transfusions, TSAT of 5% and a ferritin of 108. And then some further workup from the ED showed a reticulocyte count of 1.8% and an ESR of 111. Interestingly, her hemoglobin had actually been low back in May when she last saw a doctor. It was 7.9, and it was 9.5 a year ago, and it was normal 2 years ago. And from her May visit to her doctor, we know that her creatinine baseline was 0.6. We were consulted for the AKI. The UA showed 1+ protein, red blood cells, white blood cells, and leukosteroids, and the culture was ultimately negative. On her microscopy, she did have dysmorphic RBCs. The UPCR we got was 2.5 grams per gram, and following up a 24-hour, it was 1.6 grams of protein and 500 milligrams of albumin. Serologic workup was sent with ANA negative, ANCA negative. Celiac testing was sent as well because of this report of rash and her diarrhea. She had been on a gluten-free diet, but the celiac testing came back negative. She was Hep B, C, and HIV negative, and her complements were low, with a C4 of 9 and a C3 of 38. She had a renal ultrasound, which was normal as well. So initially, her hemoglobin improved. She got 3 units of packed red blood cells, but her creatinine remained about 1.4 to 1.5. So because of this and the dysmorphic RBCs on her microscopy, she underwent a biopsy. I can share that our differential at this point, because of her report of possible celiac disease and the rash that had improved with the gluten-free diet, we were wondering if this might be an IgA associated with celiac. I don't think the ANA had come back quite yet, and so we were very concerned about lupus with her report of rash as well. And so I think those were our 2 leading differentials when she went in for the biopsy.
Okay, so we'll move on to the biopsy, and here's a low power view, and just ask everyone to circle the area that's renal cortex in this biopsy. a little bit of a trick question, but yeah, that's pretty good. That might be a little bit of cortex up there. You're seeing some proximal tubules. How about, can anyone see glomeruli? Okay, how about if I go up to a little bit higher power? Maybe we can erase the annotations. So this is the single glomerulus that's present in the sample. It's detached, and someone identified it. Great, thank you. So looking at this glomerulus, it's hard to say too much about it. We just see some glomerular basement membranes, a few cells, a little bit distorted. The mesangium is there. There's nothing obvious that's abnormal in it, but that was essentially all that we had in the light microscopy for the sample. Now here's the immunofluorescence, and here we had trace IgG staining. We had more diffuse granular C3 staining that decorated the glomerular tuft, so C3 positive staining. And then also fibrinogen was focally present in some of the glomeruli, indicating an active glomerulonephritis. Sorry. When we went and looked at the H&E then, this is an H&E from the frozen section, and there are two glomeruli here. One of them is involved by a crescent and one of them is normal. You could put a circle around the one with the crescent and an X around the one that's normal. You bet, there we go. So yeah, so we have this one, you can see a cellular crescent on the side. We can see this bright pink material that's probably fibrin present. So there is a necrotizing glomerulonephritis, and then we do have some normal glomeruli present as well. So we have a focal necrotizing and crescentic glomerulonephritis that's C3 dominant. And then we'll move on to the electron microscopy, and much of the electron microscopy looked really pretty normal. Here you can see normal appearing glomerular basement membranes. We see the podocytes with really intact foot processes, no obvious abnormalities. We see the endothelial cells with their normal fenestrated endothelium, normal endothelial cell nucleus, and then some maybe a circulating leukocyte present as well, but that's just very focally present within some of the capillary loops. Looking a little bit further, we can see, okay, focally, there looks like there's a subendothelial electron-dense deposit here. There might be some more here in the mesangial regions or juxtamesangial regions, a little bit more here. And at higher magnification, we can see a little bit of electron-dense material present here that, correlates probably with the C3. No humps or anything like that, but we do have C3 dominant immunostaining and subendothelial and mesangial electron-dense deposits that correlate with that. So then our pathologic diagnosis, C3 dominant glomerulonephritis with focal cellular crescent formation and segmental necrosis, and that the pattern being C3 dominant is most concerning for an infection-associated glomerulonephritis. So we'll move on to the clinical follow-up.
This was early November, and she actually wanted to discharge prior to her biopsy results because she wanted to make sure her ballot was submitted, and this was Tuesday. She did get one last transfusion prior to discharge where she became febrile. There was concern for a transfusion reaction, but then she actually had reported for the first time that she had been having fevers at home up to 105 Fahrenheit. And there was a travel history obtained that she had actually gone to India in 2022. So just before discharge, she did have blood cultures drawn and a malaria and babesia smear sent. I called her with her biopsy results and requested that she come in to get an echo, which the hospitalist had ordered, but then her blood cultures a few hours later actually turned positive for Gemella. And so we called her to come back to the hospital. She got a TTE that showed a large echo density on her tricuspid valve with moderate regurg, and she had a CT scan that showed pulmonary nodules concerning for septic emboli. Because Gemella is thought to be a GI bug, She had an EGD and a colonoscopy, especially given this history of her diarrhea. They thought maybe that was the source, but it had normal findings. I think her biopsy showed H. pylori, but nothing else. And she was ultimately started on ceftriaxone for 6 weeks, and CT surgery felt there was no surgery indicated at the time for her tricuspid valve. She's had a couple of other hospitalizations in the interim for unrelated reasons, but most recently I saw that her creatinine this week had improved to 1.1.
Okay. Looks like we have a couple of either comments or questions. Some people are thinking of it.
I can
So,
talk.
okay,
Say my
go for it.
question out loud. So Megan, the iron deficiency, was that thought to be GI involvement of the Gemella?
I think, and she has chronic iron deficiency. I mean, her hemoglobin was already low in May of this year at 7.9, which I think may have been dietary related given her very strict diet. And so I think the like acute component was related to the endocarditis.
Got it. And her retic was not as high as you would expect for that, but I guess she has no iron, so that makes sense. Okay, I'm good.
Yeah, and she had stopped her iron supplements because they were causing constipation, and then the diarrhea happened. So
Got it.
So here we went through, a fairly good assortment of infection-associated glomerulonephritis cases that we've had. And one thing to remember, there's a review by Anjali Satiskar that's good, and it's listed down here. It really talks about how this has evolved over the years. And when we think of infection-associated glomerulonephritis, we oftentimes just sort of focus in on the post-streptococcal glomerulonephritis. And I think we have to remember that that's a very specific case for infection-associated glomerulonephritis, and they're actually really can be quite diverse clinical and pathologic presentations and findings. So the post-infectious glomerulonephritis is essentially like the first case that we saw, with really an acute post-streptococcal infection being the prototypical clinical case for this type of for this entity. Other glomerulonephritis that we didn't discuss is a cutaneous or mucosal infection associated glomerulonephritis, and these are oftentimes due to staphylococcal infections. Then we had a couple of cases of endocarditis associated glomerulonephritis that are typically associated with a subacute bacterial endocarditis, and that the kidney biopsy is oftentimes the diagnostic procedure that leads to the diagnosis of the endocarditis in these instances. There's also other types of infections, so the shunts and indwelling catheters and deep abscesses can also lead to infection-associated glomerulonephritis. So I didn't show you an example of a cutaneous or mucosal infection-associated glomerulonephritis, and I just wanted to show you really quickly an example of that. This is a 74-year-old man with a history of hypertension and diabetes, recent CABG, and then developed a sternal wound infection, MRSA, rash, hematuria, proteinuria, and increased serum creatinine with a positive ANA. And this is the biopsy, and this is a hypercellular biopsy. There's a few neutrophils present in here, but there's a lot of mononuclear inflammatory cells, not a lot of remodeling, but we do see, maybe some eosinophilic material present, but mostly hypercellular, a little bit more of a membranal proliferative pattern without really a lot of remodeling. Immunofluorescence shows IgA. So this is an IgA dominant immune complex mediated glomerulonephritis. And then in this instance, the electron microscopy showed a lot of immune deposits present in mesangial regions, as well as some remodeling, sort of membranal proliferative type of remodeling of the peripheral capillary walls that were at least focally present here. And so this is sort of a characteristic picture of a cutaneous or a staphylococcal infection associated glomerulonephritis that's dominated with IgA. For the endocarditis associated glomerulonephritis, there's a nice review from several years ago now that's listed at the bottom here. More common in men, Many of the patients have no known risk factor, no cardiac abnormality, no valve abnormality to suggest that they would have endocarditis. When you look at the bacteria, Staphylococcus and Streptococcus are the predominant ones, but we're seeing more commonly some of these rarer infections. So Bartonella, a common cause of a culture negative endocarditis, and then as we noted in this case, Gemella. But these are rare causes, but we're seeing these more commonly these days. So hypocomplementemia is present in around half of the cases, so it may not always be there. And then ANCA is also present in a fair number of these cases too. And that might be something that misleads people or directs people towards thinking about a post-immune complex mediated disease. The most common histologic lesion in this case is really necrotizing and crescentic glomerulonephritis. And so I think that this is important for everyone, is that when you see a necrotizing and crescentic glomerulonephritis, you should really always include an endocarditis-associated glomerulonephritis in your differential, whether it's focal or diffuse, and especially in instances when it's ANCA negative, but even when it's ANCA positive. C3 is usually going to be helpful in the immunofluorescence. So if C3 is present, we should really characterize that and help that lead and support our differential. But clinical workup is really critical. And then finally, just to remember that there's other types of infections too that could be contributing to an infection-associated glomerulonephritis. Often these have a C3 dominant and membranoproliferative pattern of injury based on our biopsy findings, but the histology can be variable. And so that's all that I had here. If there are any questions or comments, this is a great time.
Any questions, anyone? Very interesting cases this morning. As I mentioned in the chat from Guy Yuan, curious about how this patient got the infection. And looks like Megan commented no source was clearly identified, but maybe got translocation from her diarrhea. What's the thought? And Megan also mentions that there's a case series in the 90s from Harborview about connection between lice and contracting Bartonella infections. Certainly something we need to be thinking about in our patients who do present with, hopefully not a frequent thing we're seeing, but lice infections. All right, well, if no additional questions or comments, we are right on time. And so thank you everyone for attending.